Hello ladies and gentlemen. Please enjoy our video, the Inside-Out Central Venous Access Technique for Patients with Chronic Venous Occlusion, performed by Dr. Christopher Karsten at Greenville Memorial Hospital in Greenville, South Carolina. Video by Joseph Tingen, Surgical Resident. Chronic central venous occlusion can make reliable long and short-term dialysis access difficult for the vascular surgeon. This video shows 4 patients with varying degrees of central venous occlusion and the technique we utilize to create reliable short-term catheter access. The purpose of using this technique is to avoid femoral and subclavian catheters, which carry a high risk of DVT and stenosis. Our first case shows a 56-year-old man with multiple failed accesses in his bilateral upper arms due to central venous occlusion. He also has a left-sided pacemaker in place. Venous access is always obtained in the femoral vessels using ultrasound guidance and a micropuncture kit. Here we can see obvious occlusion of the right internal jugular vein. Therefore, an SL1 transeptal catheter is advanced to the confluence of the right internal jugular vein and right subclavian vein. We then used AP and oblique imaging to orient the tip of the catheter to be pointing anteriorly into the subcutaneous tissues. The back end of a confianza wire is then carefully advanced through the occluded internal jugular vein into the soft tissues of the neck and identified with a hemostat. Here we can see tinting of the skin in the right supraclavicular region where the wire has punctured the occluded vein and is ready to be retrieved in the subcutaneous tissue. After a small skin incision, the wire is easily advanced out of the occluded vein. This wire can then be used to place central access using standard techniques. A micropuncture sheath is then advanced over the externalized portion of the wire into the superior vena cava and confirmed with fluoroscopy. A tunneled dialysis catheter is then placed in a standard fashion. Our second case shows an 81-year-old female with chronic bilateral internal jugular and right innominate occlusion with a left-sided pacemaker in need of an acute dialysis access. The micropuncture kit was used with ultrasound guidance to access the femoral vein. Here we can see the right subclavian and jugular veins are occluded. An SL2 transeptal sheath was then advanced over a wire to the level of the occlusion of the right innominate vein. We then attempted to select the right internal jugular vein and were ultimately successful with the back end of a 014 confianza wire. This was pushed through the vein wall and into the subcutaneous tissues above the clavicle. A micropuncture catheter was then placed over the wire into the central venous system and luminal placement confirmed. Then a stiff Amplatz wire is then advanced from above. A tunnel dialysis catheter was then placed using a standard technique. Our third case is a 62-year-old male that requires long-term IV access for TPN and fluids. He has known occlusion of his bilateral innominate and proximal SVC. Here we can clearly see occlusion of the upper superior vena cava. An SL1 transeptal sheath and dilator were advanced over the wire to the superior vena cava occlusion site. The back end of an 014 wire was then used to perforate the occluded vena cava and exit into the subcutaneous tissue. A small skin incision was made and the wire was located with a hemostat. The wire was then further pulled out to allow supraclavicular access through the occluded veins. Here we see a procedural photo of the wire entering the left femoral vein, traversing the entire central venous system, and exiting the right internal jugular occluded vein. The wire is now ready for central access. A micropuncture sheath was advanced over the wire and into the superior vena cava. An 8 French port was then placed in typical fashion, showing this technique is also suitable for complex port placement. Our final case shows a 70-year-old female with known central venous occlusion and very unique collateral anatomy who was requiring acute dialysis access. Her left internal jugular vein appeared patent on ultrasound, however here we can see her unique collateral system. We then obtained access in her femoral vessels using ultrasound and micropuncture kit, which again display unique collateralization due to chronic occlusion. We were ultimately able to traverse these occlusions in the inferior vena cava and obtain access to her superior vena cava, where we see occlusion of the right internal jugular vein. An SL1 transeptal sheath was again used, and we were able to exit the occluded vein using the back end of a stiff microwire. A dilator was then passed, and a tunneled dialysis access was again placed in a standard fashion. This video only shows 4 unique cases of the inside-out catheter placement. However, we have performed this technique in 9 patients total to achieve venous access. We have a 100% technical success rate with no periprocedural complications and a mean access patency of 81 days. Most of these patients have gone on to receive a complex vascular access and are currently catheter-free. In conclusion, the inside-out venous access technique is a useful skill to avoid femoral and subclavian or exotic catheters in challenging patients. This procedure is performed with standard equipment commonly available in interventional suites available at most hospitals. Thank you for your time. I hope you enjoyed the video and found it educational. Special thanks to Dr. Karsten.